Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOGS Endocrinology Committee. A very warm welcome to all the respected dignitaries, faculty who are part of today's event. The theme for today's event is Key Issues in Obstetrics and Gynecology, and we are delighted to partner with Acumentis Viviana for this particular event. I would like to start by expressing my gratitude to our AMOGS office bearers. Next slide, please. Dr. Nandita Palshetkar. Madam is the president of AMOX. She is the immediate past president of FOXY, also been a president of the Mumbai Society and IAG in the past, currently vice president of VISAR, and next year she'll be taking over as the president of VISAR. Thank you very much, ma'am, for your blessings, your guidance, and for always supporting us in our academic endeavors. Next slide, please. I'd also like to express my thanks to Dr. Arun Nayak, who's the secretary of AMOX. Sir is a fantastic academician and a brilliant vaginal surgeon in his own right. Whenever he speaks about vaginal surgery, there are packed houses and there's pin drop silence. It's amazing to have such a wonderful person at the helm of affairs, along with Dr. Nandita Palshetkar, guiding us. Thank you so much, sir, for your blessings and your support always. Next slide, please. At this juncture, I'd like to express my gratitude to the ICOG chairperson, Dr. Mandakini Megh, and secretary of ICOG, Dr. Parag Biniwale, for granting us the ICOG credit points for all of our events so far, including today's event, which is accredited with one ICOG credit point. Next slide, please. We have with us three eminent stalwarts from all over the country and amongst office bearers as the chairpersons for today's event. And similarly, we have three fantastic academicians from three different parts of India who will be delivering the talks for today's event. It's my pleasure and privilege to welcome Dr. Kiran Kurtakoti, sir. Sir is the second vice president of AMOX. In the past, he has held several posts at AMOX, including chairperson for the MTP committee, chairperson for medical education, research, and training. He's been second joint secretary of AMOX in the past, also been a Foxy chairperson for the MTP committee way back in 2009 to 11, has to his credit several conferences which he has helped to organize as the organizing secretary and the convener. He's received several awards, including the Dr. Shivli Rudra Sinha Prize for Best Paper at Endoscopy at AICOG Bangalore 2019. Also won the Foxy Dr. C.S. Dawn Prize for Best Paper at AICOG in Chennai. Sir has been the editor for the Medical Abortion Foxy Focus and also authored a Foxy Focus on recurrent pregnancy loss and medical abortion drug regime. We are delighted to have Dr. Kiran Kurtakoti sir here with us. Next slide, please. We are also privileged to welcome Dr. Sujata Dalvi ma'am. She is the first joint secretary of AMOX, a consultant at several hospitals in South Mumbai, including Global, Saifi, Bhatia, St. Elizabeth, Rukshmani, and Jain group of hospitals. Also, an honorary clinical associate at the Navroz Jiwadia Maternity Hospital, the Jagjeevan Ram Railway Hospital, assistant editor of our Foxy Journal, fondly known as Jogi, and she's recently been elected as the joint clinical secretary of the Mumbai OBGYN Society. Next slide, please. Our final chairperson is none other than a brilliant academician from the South, Dr. Charmila, who incidentally did her MBBS in Coimbatore, her MD at the Grant Medical College in Mumbai. She is the immediate past chairperson for the Clinical Research Committee of FOXY from 2016 to 18, president of Menstrual Hygiene Management Consortium, director of the Aditi Hospital at Trichy, and as the secretary of Trichy OBGYN Society, she has the unique distinction of winning 5 trophies of FOXY as the secretary of that little society. Also, the recipient of Dr. Suchitra Pandit instituted award for women empowerment by FOXY and the best committee award by FOXY in 2018. She is somebody who's a fantastic academician, editor of Handbook on RPL and the ICOG campus on high risk pregnancy. We look forward to hearing from these eminent chairpersons. We have Dr. Kiran Kurtakoti sir here with us, and he is here to talk to us and introduce somebody who I feel is a very dynamic, up and coming young gynecologist who is mature and wise beyond her years, Dr. Shaila Jamal. Over to Dr. Kiran Kurtakoti, sir, and I request you to take us through the further proceedings. So please unmute.
Yeah. At the outset, welcome on behalf of AMOX to this wonderful webinar organized by Dr. Pratik Tambe under the aegis of the AMOX Endocrinology Committee. And it's my pleasure to introduce the first speaker, Dr. Sahela Jamal. As Pratik rightly said, she's an upcoming member in the FOXY. She's the North Zone in charge of the YTP Committee of FOXY, the coordinator of the Endocrinology Committee of FOXY. Her academic background is excellent. She is an alumni of the prestigious Aligarh Muslim University as well as from Kolkata. And she's also done her MRCOG. So a brilliant academician. She has won the FOXY PAC Award, Award of Excellence in Menstrual Hygiene Promotion by Gramalaya and Ministry of Sanitation and Drinking Water. She has to her credit over 39 publications and chapters, contributed a couple of chapters to FOXY Focus, and she is the founder president of the Society of Menstrual Disorders of Hygiene Management. So the stage is yours, Dr. Sahela. Welcome on this particular platform.
Thank you so much, sir, for those kind words. I'm really overwhelmed. And with your kind permission, I would like to share my screen now. So as we see in today's world, menstruation is a much talked about, thankfully. Yes, much talked about topic of discussion amongst everyone. Those who must talk about it in majority are a bit like they have taken a back seat. So our aim of today's presentation, my aim is to bring back that seat to the, the thrones of gynecologists. Let us reclaim back. So, sir, Pratik sir, I'm so thankful to you to give me this opportunity. I'm thankful to Nandita Balshetkar ma'am, to Arun Nayak sir, for giving me this opportunity, this platform, and considering me worthy of presentation today. So I'll be talking about M's of menstruation and not just issues about menstrual hygiene. So menstrual health and hygiene are an integral topic, and they are well aligned in sustainable development goals. And we have been working towards it. The whole India is working towards it. We all know there are approximately 119 million sirf adolescent girls in India, those who are menstruating at any given point of time.
Sorry to interrupt, ma'am. Could you go full screen, please?
Just a second, sir. Now is it, sir?
No, I don't see the full screen slideshow.
I think there's a slideshow button at the right bottom. Yeah, that's one.
So is it full screen now?
No.
Maybe you can stop sharing and restart sharing again. That sometimes works.
I believe it
yes,
must be.
Perfect.
So I'll talk about M's of menstruation. There are many, right from mystery to myths to euphemism to mourning and melancholy, men and money. We all will be talking and discussing about this today. So first and foremost, the mystery. Imagine way back then, when nothing was known to anybody. A woman suddenly started bleeding on her own, and then she stops bleeding on her own. There was maybe some pain, some discomfort associated with that also. Why it was occurring, why it was stopping, nothing was known. Pliny the Elder, a Roman author and natural philosopher, wrote that a nude menstruating woman could prevent hailstorms and lightning and even scare away insects from farm crops. So they utilized these menstruating females for this very purpose. In Mayan mythology, menstruation was believed to have originated as punishment after the moon goddess, who represented women's sexuality and fertility. And the women who suffered most from dysmenorrhea were considered to be the most characterless females. That is why they were being punished with pain during this bleeding episode. Mysteries continued. It was often used as a charm of sorts, based on a belief that it had powerful abilities to purify, protect, or cast spells. In fact, the blood of menstruation was fed to the husbands of females in an attempt so that they don't go haywire and they remain fidel to their females. Ancient Hebrews, they upheld the laws of Nida in which menstruating females went into seclusion and had to be separated from the rest of the society for those 7 cleaning days. In medieval Europe, things were not better. Females had to carry nosegays of sweet-smelling herbs around their necks and waists, hoping it would neutralize the odor of blood. No pain relief was allowed to them, as they were being punished for the sin Eve committed back then. Thus, the game of myths started. There is actually nothing wrong with myths, but myths which are harming our practices, which are violating our rights, are wrong. We all know the myths that are prevalent in India, those pickle stories, those kitchen stories, those religious places stories. But there are many things which we have come across from all over the world while we were doing research around menstruation. So Poland, it is believed that if a menstruating female is having sexual intercourse with a partner, the partner will die. In Malaysia, they believe as soon as the female will step out of her house while she is menstruating, the ghost will come to her and probably eat her. In Dominican Republic, every type of fluid is barred. They cannot have even a simple lemonade. In Philippines, the girl who is attaining menarche has to be slapped by different menstruating females so that her cheek remains red throughout her life. In Bolivia, it is believed that if a child is touched by a menstruating females, that child will turn out to be characterless. So there is, as I said, nothing wrong in myth, but those beliefs which are turning into harmful practices are probably the ones we need to look into. One such harmful practice is menstrual violence. We all know the separating sheds, which are very, very prevalent in eastern part of India and probably Nepal. Menstruating females are sent into menstruating sheds. They're not allowed any menstruation sanitation product. They're keeping ash behind this hut sort of thing, and the menstrual fluid goes down there. I would like to narrate few stories which I came across while I was working for this reason. One female gets beaten by stones as her punishment for menstruating every month, as her husband can't sleep with her when she menstruates. One female's husband goes out to red light area every time she menstruates, as he feels it's not fulfilling her duty as a wife. One male is keeping 2 wives. If one menstruates, he goes to another comfortably. So these are the things which were real eye-opener, and we thought, like I thought, कि menstrual hygiene is such a talked about subject. It's good that we are talking, but these are the things where we need to probably look more into. They give rise to gender inequality, inequity, and the basic human rights violation is perpetuated because of these harmful practices. So menstrual violence, lot of insecurity around menstruation. Those females, as soon as they perceive that they are about to menstruate, they used to go into depression. There's a lot of vulnerability and unsafe practices surrounded with these beliefs and myths. We all have heard stories about rags, ashes, leaves that are used as menstruation sanitation, giving rise to reproductive tract infections, UTIs, ectopics, infertility. And I'm sure this topic, though, I need not touch even because every one of us knows. But yes, what about dignified menstruation? Can they menstruate with dignity? This is the question. So solution, we don't fight with their myths. We can't fight with their beliefs, but we can give them something so strong that those myths are reduced to drafts by themselves. So such a powerful tool is education. So a lot of awareness, utilize every and any social media platform or whatever we may find for spreading awareness about menstruation, education, school assemblies, this menstruation and issues around poor menstrual sanitation practices can be brought up in school assemblies directly. We can involve sarpanch, panchayats of the villages because grassroots level changes needs grassroots level workers. And yes, of course, we can join hands with our own medical system, PHC, CHC, from the government, other field and other specialties may be invited to contribute and to join hands with us, because sometimes or many a times pediatricians are the people who are first encountering such issues in females. And yes, the role of NGOs and NPOs cannot be underrated at this point. So yes, no one else can do this for us. We are the leaders. We should involve as many people as possible. We have paramedics, we have our students, NGOs and NPOs are always ready to support these causes. And believe me, when we are doing this, no one is a threat to no one, because sometimes we feel that this area is ours. Nobody should be talking about this except for us. This should not be the outlook, and we need to change this because we need to join hands. So we can involve families, friends, make support groups, make menstrual health volunteers. All we need is a bit of effort. Second M about menstruation is menstrual euphemism, and we call it euphemism. So euphemism is nothing but ascribing some retro or derogatory remarks to describe any situation, like this thumbs down sign used by females to describe their menstruation, that yes, I'm down. Why I'm down? Why a natural process is known as down? Why we should feel down? So these are the things which we ourselves generated and we ourselves are practicing. And believe me, we still are not ready to forego this. So euphemism describes and it believes that the blood disgust to all those who were born out of it. The glory is converted into gore. Sadly, gore is accepted, but glory is dejected. We all see these highest grossing Hollywood and Bollywood movies showing lot and lot of blood, and we all seem to be enjoying it. We are giving high ratings to these movies, but the moment this menstrual blood or menstrual picture comes, we all are seeing like why this has to be shown on a national screen or national television. So we, the role of gynecologists, like we are a group of gynecologists discussing these issues, we ourselves should stop calling it as menstrual blood. We all know it is not menstrual blood, rather it is menstrual fluid consisting of endometrial tissue, and blood is just a part of it. So it should be changed from the textbook also. It's not blood, it's menstrual fluid. Third M is malevolence. Because why malevolence? Injustice is served because of some sort of physiology anatomy. It is not only a men to women issue, but a women to women issue also. Females are getting and giving unequal opportunities. A lot of menstrual shaming is prevalent. There is reduced work contribution because of this. And when we extrapolate to menstrual shaming to other sexual reproductive health rights like abortion, pregnancy, breastfeeding, it continues. So once you start shaming one aspect of physiology or biology, other aspects will fall a prey to all these practices. 58% of females have felt embarrassment from being on their period. Why? It is a women to women issue. 1 out of 5 women have felt period shame for no reason. 51% of men believe it's inappropriate for women to refer to their menstrual cycle in the workplace. Here it is men to women issue. People have committed suicide, especially young girls. Some have stopped working. Some suffer from continuous depression and anxiety. There are poor workplace relationships and dynamics and awkward questions raised like, are you on those days? Are you PMSing? So we have created a lot of fury around menstruation that you start feeling so negative about menstruation that you don't even want to talk about it. So solution again is change yourself and change 5 people around you, and that 5 people should include 3 females and 2 males. Let's make an unbreakable chain, and change will come automatically. The 2 M's associated with menstruation are mourning and melancholy. The moment we think that yes, we are about to menstruate, we start winding up our things, like we won't keep our operations, especially long OTs when we are menstruating. We would like to take our CLs and we keep them accumulated so that we can utilize it on the day we start menstruating. So this is our own thought process, our own practices, our own perception, which is decreasing our menstrual quality of life index. So this particular alignment should be discouraged by one and all, and for once and forever. So if I ask females or the girls who are seeing this, try to recall your first period, the last conversation you had about your periods, last time one felt happy while menstruating, except for the fact that we were dreading pregnancy, and yes, we did not turn out to be pregnant and we menstruated. I think that's the only time we felt happy ki yes, we have menstruated. Otherwise, 97% have negative experiences or emotions associated with their menstruation. So we can employ some menstrual quality of life improvement tools like affirmation, accepting it, maintaining good menstrual diet, exercises, and so many things, so many interventions which improve this MQLI. Second, last M of menstruation is menstrual closet. We all know that we wear dark colored clothes, we have a secret pocket, a secret place, secret disposal facilities. You have to wrap it around in a newspaper. What if somebody comes to know that you are a female, you have a uterus, you're bleeding, you're using some sanitation product and you have disposed it? So this is the disgust associated with menstruation. Nobody should ever come to know that you are menstruating. You should never stain your clothes. If you stain your clothes, you are put to a lot of menstrual shaming. And yes, as I said earlier, 2 girls recently committed suicide because of this. And yes, men and money in menstruation, it is very interesting. For once, we can find some men who may say, oh dear God, they're bleeding, they're menstruating. And for some time, we may feel, and we may find men like Padman of India so supportive. So, money, yes, it's a big issue, and that we would like to discuss later. So, a few things about menarche, menducation, and menoments. So, menarche, to me, a lot of things depend on introduction, like the way chairpersons introduce speakers using lovely words. So, we will never be able to forget how I was introduced in that conference, and probably I'll have a very good sleep today. Yes, those beautiful words used for me. So it all depends on how we introduce the subject. So let us build up some practices like gifting some things, giving them gifts, some books, or something that makes that girl feel happy. We should be making it a habit that we will relieve one fact about menstrual cycle in one cycle and one gift about related to her menstruation in one cycle. And believe me, the change will come. The girls will feel more comfortable about talking menstruation. Menducation, yes, we have to involve boys also, because if I talk about my son today, I would like to divulge each and every information about menstrual practices, menstruation, rather than he resorting to some unverified information. And that is the reason why many young boys fall to the clutches of pornography. A lot of pornography comes in when they are curious about females, their body, and the menstruation. And menoments, as I said earlier, let us try to create beautiful memories associated with menstruation. So financial money that we were talking about, financial dependence is a lot. That cost is a big factor. Thus, quality of menstrual sanitation can be compromised. If I want to use a good quality product, maybe I'm having no money to afford that, because we are always dependent on the male counterparts because they are the bread earners. So this vicious cycle is set in. And one very sad part is that while people are making money out of menstruation, selling pads, doing everything, those who menstruate are suffering due to lack of it. And this is the ground reality. So what we can do, again, as I said, join hands, provide some aids, dispenser, some subsidy can be thought. Or the government of India has put in a very nice and a truly laudable effort of giving subsidized pads. But yes, the reach is yet to reach the masses where it has to. So these are the areas where they have to go. The slum areas, maybe some minimal aids are present, but they're not sufficient. Till date, I could reach only 32 slum areas. And according to the data, India has 1.2 million slum areas, both rural and urban. So 1.32 million versus 32. So it's a long way ahead. And this area, tribal areas, only few, and data is not available. What practices they are having, how do they manage? It is beyond our imagination only. So we have just difficulties ahead. We have to stop certain things like calling menstrual blood as menstrual blood. We should call it as menstrual fluid. Period days versus normal days, this particular talk should be condemned. There are no period days. Every day is normal day. Conversations around menstruation should be generated as we have generated today. Thank you, Pratik sir, for bringing out this matter. And yes, we should always believe that we can normalize only when we want to. You closing my eyes, I closing your eyes will not bring anything, any good, any change. So let us face it. Our conditioning or social relations are rooted in the belief that period is impure, women's sexuality is a stigma, and her restriction is the norm. So if we change this, change is just ahead. We just have to motivate, put in some efforts, and join hands. Thank you so much.
Fantastic, fantastic talk. I mean, I didn't realize before I sat as a chairperson, I thought that what were you exactly going to talk on? But fabulous. I mean, I didn't imagine that a menstrual cycle issue could be discussed so much at length, and probably all the MMM as well as we men being involved in that so critically. And anyway, so good take home messages, and definitely your point of replacing this menstrual blood with menstrual fluid is a point which is really well taken, because we do understand the physiology behind that. So fantastic. And so also your break the chain, that is involve five more people, of which at least two should be males. So they, definitely that is also a point to be worth a thought. So thank you so much. Any questions from the audience, if at all? Are there any questions?
So far, there is nothing, sir. In case there is
are only
anything,
good
we'll take
comments.
questions later.
Dr. Jamal, there are only good comments. I mean, really, I appreciate your talk.
Thank you, sir.
Thank you. Thank you.
So we have Dr. Charmila here with us. You've already been formally introduced, ma'am.
After that wonderful talk by Sheila, let me tell you, I'm the president of the Menstrual Hygiene Management Consortium of Tamil Nadu. So in our group, we have got males also, and one of them has got the Padma Shri Award for this year for his work on eco-friendly toilets for women, girls in schools particularly. And we have gone into the field for almost 10 years and working on that. I'm so happy to hear somebody young talk so much on menstrual hygiene issues, which has been an old problem, but not given that due importance which is needs. And thank you so much. That's a wonderful talk. And I've got the honor of inviting a speaker who's such a hardworking Foxy leader. And it's my honor to introduce Dr. Lakshmi Shrikande, madam. She's a medical director of the Shrikande Fertility Clinic, Nagpur, chairperson designate of Indian College of Obstetrics and Gynecology 2020. She's a national corresponding editor of the Journal of OB-GYN India, JOGI, national corresponding secretary of the all medical women associations, and the senior vice president of Foxy in 2012, founder, patron and president of ISAPA Vidarbha chapter. She has received the Nagpur Ratan Award at the hands of the Union Minister Sir Nitin G. Gadkari. She has received the Bharat Excellence Award for Women's Health, has received several awards, and she's delivered 11 orations and almost 450 guest lectures. She's got 20 publications nationally and 11 international publications. She has sensitized 2 lakh boys and girls on adolescent health issues. I welcome you, madam, to give your talk on recent advances in medical management of fibroids.
Thank you. Thank you so much, Charmila, for your kind introduction. Shaila, I must say that your talk was very good and it was an eye-opener. This Sunday, I am taking over as president of Association of Medical Women Nagpur, and I will definitely include these menstrual hygiene issues in our agenda, because I am there for 3 years, and I hope we can really something contribute to this cause. So thank you so much for bringing out these issues so clearly and telling us what are the issues associated with menstrual hygiene. So I really appreciated it, and very good talk. Now, very good afternoon, dear friends. Today, my topic of deliberation is recent advances in the medical management of uterine fibroids. First, let us revise certain basic facts before we go towards the recent advances. We all know fibroids are common concern for the woman who wants to have a child. It gives the bleeding and pain which affects the quality of life. 20 to 30% of women in their reproductive age, they do face the problem of fibroids, and at any given time, nearly 15 to 25 million Indian women, they have uterine fibroids. We all know the types. Intramural constitute 75%. They are within the wall of the uterus. Submucous fibroids constitute 15%. They are in the endometrial layer, that is within the uterine cavity. Subserosal fibroids constitutes 10%. They are on the surface of the uterus, and sometimes we have a special category, that is we can have pedunculated submucosal fibroids or pedunculated subserosal fibroids, which makes the life of surgeon very, very easy if it is pedunculated. These are some of the symptoms. Woman can approach you with the complaints of menorrhagia, dysmenorrhea, pelvic pain. Sometimes if fibroid is large and pressing on the bladder, patient can have urinary incontinency. Some women, they have issue of infertility because of fibroids, and if she is having heavy menstrual bleeding because of fibroid, then certainly that woman can land into anemia. Whenever we diagnose fibroid in our OPD, we are left with two options, either surgical or medical management. Surgical, we all know, hysterectomy, myomectomy, uterine artery embolization, but today I am focusing on medical treatment. There is a list of medical treatment which is available in our armamentarium, right from NSAIDs, antifibrinolytics, GnRH analogs, progestins, danazol, combined oral contraceptive pills, and selective progesterone receptor modulators. So currently the treatment options which are available to us, I have enumerated it. Also, I would like to add the LNG to it, and LNG has a role in certain cases of fibroids. These are all hormonal medical options, but hormonal category. Do we have some natural options? Because nowadays patients are going more towards the natural thing, whether it is natural treatment or natural diet or whatever. So this natural medical option is certainly available with us nowadays, and these options contains Cryptergium wilfordii, epigalactogen galatate, and vitamin D. We also have recently available oral antagonist with us. They have their own advantages and disadvantages, and it is FDA approved for the medical management of fibroids. Let us have a look at the limitations of the surgical treatment modalities. When we are talking of hysterectomy, of course, it has got surgical morbidity. There can be some long-term complications, and once you remove the uterus, patient completely loses the fertility aspect. If we resort to myomectomy, of course, the chances of recurrence are always there, and after myomectomy, if she becomes pregnant, there are certain set of complications which we have to be worried about, and the most important of that is potential chance of uterine rupture during pregnancy or in labor. If we are resorting to uterine artery embolization, then it has got its own set of complications and limitations in the form of recurrence, pain, possibility of complications, possibility of patient landing into subsequent hysterectomy in almost 20% cases. It needs interventional radiologist to do the procedure. if it affects the ovarian supply, can lead to ovarian failure in future. And if this patient becomes pregnant after uterine artery embolization, she can have abnormal placental development. So now, after knowing the limitations of the surgical aspects, let us go towards the medical management one by one. What about GnRH analogs? GnRH is a rapidly metabolized decapeptide which is produced and released from anterior hypothalamic area. It reaches the anterior pituitary through the portal system, believed to bind to specific receptors in the anterior pituitary, stimulates the synthesis and secretion of LH and FSH in both man and woman. Half-life in the peripheral circulation is 2 to 4 minutes, and analogs with agonistic or antagonistic properties, they have been synthesized and are available to us for clinical use. When we use these GnRH analogs, we get 35 to 65% reduction in the size of uterine fibroids. It also reduces intraoperative blood loss, decreases hospital stay, and it helps convert some laparotomies into minimally invasive procedures. However, regrowth of fibroids to pre-treatment size within months of cessation of GnRH therapy is a possibility. It sometimes makes surgical planes indistinct, thereby making surgery difficult and preoperative. If you want to use GnRH analogs, you can give depot leuprolide 3.75 mg per month for 3 months, and this is the FDA approved. You certainly can't give this depot injection for more than 6 months. And whenever you are giving depot injection, please prescribe calcium tablets along with it, as one of the complications of GnRH analog is osteoporosis in these women. Now, the second medical management option which was available to us and it was launched with great fanfare was ulipristal acetate. Ulipristal acetate, now we all know that it has been banned, or rather I will say its use has been held up because of various reports that the dose of ulipristal acetate which is recommended in fibroid cases, that is 5 mg OD, can cause liver injury in some women. Friends, these two issues are different issues. What I have shown you on my second line is ulipristal acetate stat dose of 30 mg is FDA approved and is approved by Indian government also for emergency contraception. So you can use 30 mg stat for emergency contraception without worrying about the liver injury. But you can't use ulipristal acetate for medical management of fibroid because its use has been on hold pending further data which we will get. So now let us come to the limitations of various medical management. When you are prescribing NSAID, there is certainly lack of supportive evidence. It can lead to GI side effects. There is risk of gastric ulceration. Antifibrinolytics, they will definitely help to treat menorrhagia and dysmenorrhea, but how far it will reduce the myoma size is not certain. GnRH agonist, we have already discussed in detail. What about its side effects? Yes, it can lead to hot flushes, vaginal dryness, and decreased libido. It can lead to osteoporosis. That is why I already said calcium supplementation should be given as long as she is on depot preparation. You cannot give it for more than 6 months. It is not safe and contraindicated in adolescents. Injections, yes, we give intramuscular. It's a depot injection, so can be painful. Risk of recurrence is certainly there, and many of our patients might not be able to afford the depot injection. Danazol, practically speaking, we all have stopped using in our day-to-day practice. It has got many side effects in the form of acne, hirsutism, edema. It might be associated with liver toxicity, musculoskeletal pain. So it is not a treatment of choice for us when it comes to managing fibroids medically. Progestins, definitely it will help you to treat menorrhagia and dysmenorrhea. If patient forgets or if she is not properly compliant, it can lead to breakthrough bleeding, and how far it is helpful in reducing the size of myoma is still not certain. COC has got its own side effects, and whenever you are prescribing COC, please see correctly and rule out the contraindications for estrogen use, and then only go and prescribe combined oral contraceptive pills for medical management of fibroids. This is again, we are coming back to ulipristal acetate. You can read the Pharmacovigilance Risk Assessment Committee. They have reviewed and they have said that ulipristal acetate can cause liver injury. Patients are at risk of liver injury. So even if your patient is not having any history of liver injury, you are not supposed to prescribe ulipristal acetate. These are case reports, you all must have gone through it, and there are various studies also available freely on PubMed, whereby they have said currently ulipristal acetate should not be used for the medical management of uterine fibroids. Now come and look at the role the estrogen and progesterone, they play very vital in estrogen and progesterones, they play a vital role in the development of uterine fibroids. Estrogen and progesterone, they bind to their respective receptors and thereby they increase the secretion of growth factors, leads to fibroid cell proliferation, and this cell proliferation leads to increase in the size of fibroids. Catechol O methyl transferase, that is formed an enzyme that is recently linked to the pathogenesis of fibroids. It is highly expressed in uterine fibroid compared with normal myometrium, and as you all can see that this 2,4-hydroxyestradiol has got anti-estrogen activity. When COMT acts on it, the 2,4-methoxyestradiol is converted to it and this has estrogen activity. What is the role of TGF-B3? It has been found that TGF-B3 is elevated 3 to 5-fold in fibroids in cases with, as compared to the cases with normal myometrium, which does not have fibroids. The ECM overproduction by inducing collagen type 1, fibronectin, and proteoglycan. This TGF-B3 is a key regulator of cell growth and differentiation. It causes inflammation and apoptosis. This is the study published recently in October 2012, where they have read the role of vitamin D and transforming growth factor B3 serum concentrations, obesity, and family history on the risk of uterine fibroids. And as you all can see in the results, significantly lower levels of 25-hydroxyvitamin D3 was found in those patients who were having uterine fibroids. Thus, vitamin D may be a potential protective factor against the development of uterine fibroids. Increased TGF-B3 concentration associated with increased risk of uterine fibroids, and therefore TGF-beta3 may become a useful tool for detecting an increased risk for uterine fibroids. So this is the mechanism, this is the theory which has been promoted, that increased estrogen and progesterone receptor expression, increased COMT expression, increased TGF-beta3 expression, all these contributes to the growth of uterine fibroids. And therefore, when we are talking of medical management of uterine fibroids, we have to take care of all these major etiological factors. So now this new molecule is available. It acts on both progesterone as well as estrogen receptors. It hit the newer target of fibroid, that is catechol O methyl transferase, COMT, and transforming growth factor beta. This novel non-hormonal therapy, it has 3 components. It contains tripterigium bilfodin 20 mg, green tea extract 400 mg, and vitamin D3 1000 IU. the main active constituent is triptolide, that is terpenoid. So let us know something about this newer molecule. First, let us go through the review of literature. This was the study published in 2008 about the clinical application of Tripterigium wilfordi for treatment of gynecological diseases including fibroids. And you can see that the clinical therapeutic trials of this molecule on endometriosis, leiomyomas, dysfunctional uterine tumor, bleeding, and some tumors of women, they have been carried out, and it can be proved an effective new drug for the treatment of gynecological diseases including fibroids. It inhibits the expression of estrogen and progesterone receptors and thus reduces the estrogen and progesterone biological effect in fibroid tissue, decreases anti-apoptic factor BCI2 and increases apoptic factor caspase 3, inhibits aromatase enzyme, and it reversibly inhibits function of ovary and interrupt ovarian follicular development, so it inhibits ovulation and induces amenorrhea. By all these mechanisms, it reduces the fibroid size and it helps in reducing the menstrual blood loss. This is the study published in Cochrane database in 2013 about the herbal preparations. And this was the review about the use of herbal preparations for uterine fibroids. And Cochrane has said that compared with conventional medications, Tripterigium wilfordi, it may have a special effect on reducing the volume of uterine fibroids. EGCG has potent anti-COMT activity, as we have already seen in our previous slides, and therefore it reduces fibroid size by its anti-proliferative activity. It has all the strong anti-fibrotic agent. It reduces TGF-beta expression, reduces the expression of collagen type 1 and fibronectin, decreased extracellular matrix production, thereby anti-proliferative agent, and it reduces the expression of PCMA. So friends, you can see in this slide that this new molecule, Tripterigium wilfordi, it reduces estrogen progesterone receptor expression, the EGCG reduces COMT expression, vitamin D3 reduces TGF-beta 3 expression, and therefore with all these mechanisms, it helps to reduce the size of uterine fibroids. This is a study published to observe the therapeutic effect of Tripterigium wilfordi HOOK-F on patients with uterine leiomyomas. And as you all can see in the results, that significant decrease in leiomyoma volume was detected in almost 35 to 65% of patients after 3 to 4 months of treatment. And the authors concluded that Tripterigium wilfordi HOOK-F may be an effective therapeutic agent for leiomyomas with fewer side effects. It showed a reversibly inhibitory effect on the ovary, and it may be one of the mechanisms of Tripterigium wilfordi HOOK-F in decreasing the leiomyoma volume. So the benefits of this new molecule is it reduces menstrual blood loss. Therefore, definitely it will lead to increase in hemoglobin level. It decreases fibroid volume. Therefore, decrease in uterine volume, decrease in progesterone levels, decrease in estrogen level, and regularization of menses is seen after 1 to 3 months of stopping the therapy. This was the pilot double-blind placebo-controlled clinical trial where 33 premenopausal women with myoma size of more than 2 centimeter cubic were treated. The treatment duration was 4 months, and the outcome seen was the mean change in uterine leiomyoma volume, the mean change in fibroid-specific symptom severity, and the mean change in fibroid-specific health-related quality of life. And as you can see that mean total fibroid volume dramatically decreased by 32.6% in the EGCG group, whereby the placebo group showed an average increase of 24.2%. EGCG group, there was the mean change in symptom severity score amounting to 25.28. Quality of life score increased by 20.7 in the EGCG group. Significant decrease was seen in blood loss and increased hemoglobin levels were observed for patients who were treated with EGCG. It is a well-tolerated treatment. There was no adverse effect found in the study and there were no abnormalities found when they did liver function test. So the authors concluded that EGCG shows promise as a safe and effective therapeutic agent for women with symptomatic uterine fibroids. Such a simple, inexpensive, and orally administered therapy can improve women's health globally. This was the study about correlation of low serum vitamin D with uterine leiomyoma. This was a systemic review and meta-analysis of 9 studies with 1730 participants. Out of those, 835 had uterine fibroids and 895 were controls. And the result of this study was serum vitamin D levels were significantly lower in fibroid patients. The National Institute of Environmental Health Sciences, in its study, they also published that uterine fibroid study, they have shown the decreased levels of vitamin D in all patients who have uterine fibroids. So friends, uterine fibroids, they expressed reduced levels of vitamin D receptor. This might be a risk factor for fibroid pathogenesis. 1,25-dihydroxyvitamin D3 may have potential as an effective therapeutic agent for uterine fibroid treatment. This was a randomized control study published in 2016, where 108 women with uterine fibroid and hypovitaminosis were treated. Study group was 53 and control was 55. Duration was 12 months and outcome was the rate of progression to extensive diseases. And it was observed that vitamin D3 level increased significantly in study group. Rate of women with progression to extensive disease was significantly lower in the study group, and fibroid diameter and volume increased significantly in the control group. So the authors concluded that supplementation therapy with 25-hydroxyvitamin D3 restores normal vitamin D serum levels in those women with small fibroids. In these women, vitamin D supplementation seems to reduce the progression to an extensive disease, and thus it might eliminate the need for further surgery. This was a pilot study in 30 adult women with uterine myomas. In the treatment group, they gave 25 microgram of vitamin D plus 150 milligram of EGCG plus 5 milligram of vitamin B6, 2 tablets daily. Control group, no treatment was given. Duration of study was 4 months, and the difference in total myoma volume in the treated group, it was found the decrease in myoma volume to the tune of 34.7% in the treatment group. Treatment group also had reduction in symptom severity and improvement in quality of life. So friends, the newer molecule indications are symptomatic management of uterine fibroids. It can also be used in the preoperative management of uterine fibroid. The dose is 1 capsule twice a day. Give it for minimum 3 to 6 months, and therapy can be started from any day of the menstrual cycle. This molecule promises to reduce the fibroid size and volume, controls anemia due to fibroid-induced menorrhagia. Menstruation resumes once the therapy is stopped. It suppresses the disease progression, improves the health-related quality of life, and it is safe and well tolerated. This is the final slide, which has compared this new molecule with the hormonal medical management. And this new molecule is a non-hormonal therapy which is available to us in the oral form. So you all will agree, whenever we have an option between hormonal and non-hormonal therapy, it always goes in favor of non-hormonal therapy, as it is more safe compared to the hormonal methods. And this new molecule is safe for liver and kidney, and it can be started on any day of the cycle. So friends, this new molecule looks promising. It's worth trying. Give it a try and let us see how far it helps us in managing our women medically who are having uterine fibroids. Thank you so much. Thank you for your patient hearing.
It was a wonderful talk, ma'am. Very clear, very comprehensive on a novel molecule. I think we need to try it out because the other forms of therapy have got their own complications and side effects. I don't see any questions in the Q&A box. Pratik?
No, ma'am, there are no questions so far. There was one question which was regarding ulipristal acetate, but madam has already addressed
Cleared.
that during her talk. I think Dr. Sujata Dave ma'am is head up in the clinic. She was to join a little late. We will proceed with the next speaker. We are privileged to have Dr. Fessy Louis with us. I would request Dr. Chamila ma'am to please introduce our speaker.
Yeah, thank you, Pratik. It's my honor to introduce Dr. Fessy Louis, the Vice President-elect for this year. He'll be taking over next week. He's the Senior Consultant and Associate Professor in charge, MCH course, Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Sciences, Cochin, Kerala. He's the ISAR National Executive Member and the ICOG Governing Council Member elect for 2021. Welcome, Dr. Fessy, for your talk on ovulation stimulation, ovarian stimulation.
Okay, thank you. Thank you for the nice introduction. I think first of all, let me thank Pradeep, who is the MOGS Endocrinology Committee Chairperson, also the President Nandita Madam, and also Secretary Dr. Arun Naik for giving me a chance here. And it is a proud privilege to be back in MOGS, even though virtually amidst all our good old friends to be give the talk about the ovulation induction. So without wasting time, I will go to the talk. I will just tell, because the time is limited, I will be talking about the stimulation protocols and few things. How will you decide that? And I'll be little bit focusing about the control ovarian stimulation also. I will come to that and we'll have a healthy discussion at the end. So this is the basic slide which you all have studied right from the MBBS times, where the ovulation is controlled by the HPO axis. From the hypothalamus, GnRH is produced in the pulsatile fashion, and if there is that pulsatile fashion, from the pituitary, FSH and LH is produced, and with that ovulation, follicles start developing, and this is being negatively controlled by the estrogen produced by the suppression effect on the HPO axis. So if you look into the different ovulatory disturbance of WHO class, that is group 1 is hypogonadotropic hypoestrogen. That is the thing which you have to always make sure by seeing the hormonal levels. Or the most common is the group 2, which is normogonadotropic normoestrogenic group. And also we have to differentiate whether the group 3, that is hypergonadotropic anovulation, which is a primary ovarian failure problems. So in hypogonadotropic hypergonadism, it is type 1, where the FSH and LH and estrogen will be very less. That is, even though it's not very rare, but we have to anticipate that when we see patients with irregular periods and irregular ovulation. So before that, we will see what happens to the normal ovulation. So normally, after that, when the FSH is produced, it will act on the ovary to produce the follicles. And when the estrogen is produced from the follicles, it will have a negative feedback effect. So the remaining follicles will go for atresia and monofollicular ovulation takes place. This is what happens normally. But as I told previously, we must always try to differentiate whether it is group 1, where the FSH and LH is very low. And in those patients, we have to give daily injection of a combination of FSH and LH. Initially, people had tried GnRH subcutaneous infusion pump. That is not found to be practically possible. I just put it to, we must differentiate this specifically in those patients where FSH and LH will be low. So that is the thing which is important. That can be congenital or due to the secondary reason also. But as you all know, the most common type is the WHO type 2, where the PCOS fall into that. Here the diagnosis, I'm not going to the diagnostic features completely because that will be I mean, we cannot complete the other topics otherwise. So let us see what happens for ovulation PCOS. So there is one second, let me minimize this. Okay. There is this supraphysiological synthesis of estrogen is there. So there is the negative feedback signals to the hypothalamus and pituitary is there, which is express as strong signals. So the gonadotropins by the low gonadotropins production is less because of the low GnRH productions. So there is low FSH and LH. So there is an ovulation. This is what happens in the PCOS patients. So what will you do for doing the ovulation induction when your aims of ovulation induction to correct the dysovulation or anovulation, or if we go for a superovulation, that is just like for IUI, or just like control ovarian hyperstimulation for assisted reproductive techniques where the ovulation is under your control and ovulation must not take place. So before going to the other details, let us see how do you do the infertility management in PCOS. It is not the ovulation induction initially, but we must always advise the lifestyle changes and then goes for the ovulation induction. So we have to we can try metformin and other insulin sensitizing drugs also, and then there is an options of laparoscopic ovarian surgery is there, and lastly in vitro fertilization is there. So what are the drugs for ovulation induction? We can try with metformin or antiestrogens like clomiphene citrate or tamoxifen, aromatase inhibitors like letrozole or anastrozole, or gonadotropins like HMG, highly purified FSH or recombinant FSH. So to start with clomiphene citrate, we have been using it since 1960s. And it's a partially selective estrogen receptor modulator. It induces changes in the GnRH pulse frequency and increases FSH level and promotes follicular development. And the main problem with clomiphene citrate is that it has got a high ovulation rate, that is 60 to 80%, but the pregnancy rate is only 30 to 40%. That is the main problem with the clomiphene citrate. Let us see what is the reason for it. It is because mainly it has got an anti-estrogenic effects contributing to reduce pregnancy rate on the endometrium and on the cervix also is there. So this leading to a decreased pregnancy rate and increased miscarriage rate in those patients. So how do we give clomiphene citrate? We start with from the second or fifth day. You can start up to fifth day. You can go for 5 days. There is no difference between the onset of action. You can start with 50 milligram, and we can give up to 150, but I practically give only 100 milligram maximum dose because of the anti-estrogenic action. And even with the oral clomiphene citrate, we must always look for patients can go for hyperstimulation syndrome. And according to the 2008, that is older SRM Tasselsky criteria, clomiphene citrate was the first line therapy. And if you look the larger studies, this is one study I call, this is a pretty old study. Even if you do for a larger number of nearly 6,000 patients, there is still discrepancy between clomulation rate and pregnancy rate is there. Similarly, if you continue it for more months also, there is a discrepancy between ovulation rate and pregnancy rate is there. So it is not advisable. Even if you give more cycle, it may be effective. So then comes we must be knowing about the definition of clomiphene resistance and failure. The resistance is the failure to ovulate after 2 to 3 successive cycles of clomiphene at a maximum dose, and failure is women who respond normally to clomiphene but fail to conceive after 6 cycles of treatment. So what will you do in patients with clomiphene resistant PCOS? If it is obese, we have not done any lifestyle modification, we must tell them we must go for a diet and exercises, especially if BMI is high, even though Indian recommendation is BMI is more than 27, Asian recommendation. Or if non-obese, we can add metformin or with clomiphene or letrozole instead of that we can give. And still not responding, we can go for gonadotropins or laparoscopic ovarian drilling, and lastly only in vitro fertilization. So next molecule we must be knowing about is that aromatase inhibitor. So it is aromatase and anastrozole are third generation aromatase inhibitors. It has got only short half-life, 45 hours, and it is well absorbed in the body, well excreted. And the action is that it inhibits aromatase in the ovaries and the peripheral tissue, reducing the estrogen levels. So the negative feedback during the activity stimulates the hypothalamus pituitary axis. So the GnRH release produces FSH, but but the rising estrogen levels from the follicles suppresses the FSH, leaving single dominant follicle because it has got only less half-life and the peripheral action is less. That is why when using letrozole, the chance of hyperstimulation is less, multiple pregnancy is less. So to understand it better, we have to just see this picture in the day 5. You can see when you see at the day 5, still the FSH production is high when we use clomiphene citrate and letrozole. But when we use letrozole, if you see after 5 days, that is day 10, the FSH stimulation is less because the growing follicle lead to rise in estrogen levels, and these levels suppresses the further production of the gonadotropin. So the main difference you can see after the initial 5 days, that is by 10th day, in the clomiphene group, the rising estrogen levels by the growing follicle are still perceived very low. So the hyperstimulation is more, multiple pregnancy result is chances are more. So dosage is we can give from 2.5 milligram to 7.5 milligram. You can start any day from 3 to 7 days. So, or there are other regimes as 20 milligram single dose, step-up protocol, or even extended regime is there where you give 2.5 milligram for 10 days. Also is there. So the usual recommended is 5 milligram for 5 days, from any day from 3 to 7 days. That is a user recommended dose. But initially, when we were using in the 2002-3 at that time, and by 2008, there were some studies about the safety aspect of the letrozole, whether it will produce congenital anomalies. Afterwards, a lot of studies have come into tell that letrozole is effective. Even Indian studies is there by Sharma et al. And larger studies by 2017, and even BMJ has come out with a study telling the letrozole use does not increase the risk of congenital anomalies in newborn. So when we compare letrozole and clomiphene for PCOS, we can see the anti-estrogen effect is less, miscarriage rate is less, OHS risk is less, and multiple pregnancy chance is less with the letrozole. So this was the recommendation for PCOS. That is what I told initially, a SRM group, where the first line was clomiphene, then letrozole, metformin only patients with hyperandrogenic features, and gonadotropins, and always watch for OHSS. But recently in 2018, there is new international evidence-based guidelines for polycystic ovarian syndrome has been formulated by 13 different societies, including ASRM, SHRI, and PCOS Society of India also. So there are few things for diagnosis criteria, like number for follicle number per ovary, and what is the transducer frequency we have to use to diagnose as come. I'm not going to those details. But regarding the ovulation induction, they are considering that letrozole as the first line, and in failed cases you can go for clomiphene citrate or clomiphene with metformin or gonadotropins, and the second line is the gonadotropins or laparoscopic ovarian surgery. In failed patients, this is the alternate therapies, and lastly only IVF. So coming to the metformin, we all have been using metformin for many years, but when you look at for a ovulation induction agent, it is not found to be superior. But when we combine with clomiphene, definitely it has got a much superior effect as ovulation induction and pregnancy and conception. Live birth rate is more. But there are only few studies of combining letrozole with metformin, but a lot of good studies are there clomiphene with metformin. And even when the patient is going for IVF stimulation, that is control ovarian stimulation, the chance of hyperstimulation is less if you are comparing with if you are pre-treating or giving metformin to those patients during the stimulation. So next is the gonadotropins, as we discussed. The purpose of gonadotropins is that the initiation and maintenance of the follicles may be achieved by the transient increase in the FSH above a threshold dose for the sufficient duration to generate a limited number of developing follicles. That means we have to give gonadotropins so that the threshold is more, so that follicles start developing. But definitely there is always a risk of hyperstimulation is there. That can be understood if you see this picture because estrogen feedback doesn't work with exogenous FSH, because we are giving exogenous FSH, so follicles start developing. So definitely hyperstimulation will be there. Hyperstimulation syndrome chance and multiple pregnancy are there when we give exogenous gonadotropins. So if you look into the gonadotropin history, it has been, we have been using for many years, and initially the purer forms were not there. Then recombinant FSH developed in 1996, and the polyfollicropin alpha, that is single dose lasting for 6 days, came afterwards. And in pipeline is the oral FSH, which is not yet come. Even the polyfollicropin alpha is not come in India, even though it is available in abroad for last 5-6 years. So what are the different gonadotropins available? Gonadotropins available are HMG is there, human monophosphate gonadotropin, or purified urinary FSH is there, or recombinant FSH. Recombinant FSH means there is, if it is recombinant FSH means there won't be any component of the LH. In HMG, there will be FSH and LH in the 1:1 ratio will be there. Even in highly purified, there will be little bit of LH. So that is one advantage with the recombinant FSH, but it is very costly. The other advantage is that batch consistency is there. But right now, more and more purified HMGs are available, which give equally good result as the recombinant FSH. And when you use gonadotropins, most accepted or most people use regime is when you combine clomifene or letrozole with HMGs, that means or FSH preparation. That clomifene we give 50 to 100 milligram per day, just like what we told, or letrozole 2.5 or 5 milligram from second or 6th day onwards, or to second or third day, initial 5 days, followed by gonadotropin. This is the most cost-effective treatment, but hyperstimulation can occur with that also. So we have to clearly monitor the patient when we are using gonadotropins. And if the patient is having chances for hyperstimulation, we have to individualize the stimulation protocol using the ultrasound and titrating the dose of gonadotropins. So there are a lot of regimes are there, practically like classic step up, where we increase the gonadotropins, or we increase slowly. A chronic load as well increase after 14 days only. But the thing is that this always carry a time frame, because stimulation has to be prolonged for 2 weeks or 3 weeks. Patient get impatient, doctor will get impatient. So it is not many people are widely practicing that in our country, because patient will be really impatient. But in European countries, where the patient goes for one, where it is covered by the health system, few cycles of the ovulation where the patient gets treatment free, they have to go to some place. So they will try to titrate the dose and do the stimulation accordingly. So I'm not going to that, because that is a different ball game. So I'm not going to that. So next is that control over supra-ovulation, basically for IVF stimulation. So this is what the stimulation which I told, which occurs in the normally. So when we give GnRH agonist or antagonist, so there is no that pulsatile fashion is not there, whether it is GnRH agonist or when we give antagonist, it suppresses the receptors, so there is no FSH-LH. So we give exogenous FSH and the follicles are formed, then we give HCG, and before the follicles rupture, we retrieve those eggs. That is what happening, control over supra-ovulation. This is the commonest, initial triad of a long protocol using GnRH agonist, where we initially give GnRH agonist. When we give agonist, because of agonist action on the receptors, there will be a stimulation, that is the flare-up effect of the receptors. But since there is no pulsatile fashion is not there, the receptors will get desensitized and it will get suppressed. Then after the periods, we add the gonadotropins along with that GnRH agonist. And when the follicles is 17-18 millimeter with good endometrium, we give HCG. This is a costly regime. This is usually done for IVF only. Only rarely the patient is not responding for routine PCOS stimulation, it is advised because of to suppress the FLH level. And initially, people were using short protocol, where after the second third of the period, along with the gonadotropins agonist is started. So, but that the yield of oocytes is less, so less people are doing that. But recently, this is what that I told, a short agonist protocol. But with the advent of a GnRH antagonist, which came a few years back, maybe 7 years back, when we give antagonists, directly suppress the receptors. So there is no flare-up effect. There is less number of injections. It is being used along with initially gonadotropins is given, and when the follicles are either 13 millimeter or after 5 days of the stimulation, there are two ways, either fixed or the flexible protocol. We give antagonist. So then the HPICs get suppressed directly and do the retrieval of the oocyte. This is being done for the routine ovulation induction other than ART stimulation, IVF stimulation also. But the stimulation, as I told, when you use suppress the HPICs, the cost will go up. It is indicated only in patients with ILS and PCOS. So two types of antagonist molecules is available. One is cetrelix and other is ganirelix. This is what I told. It is started after 5 days, that is fixed regime, usually given as 0.25 milligram daily dose. There is a single dose regime is there, but it's not available in India. That single dose 3 milligram preparation is not available. So this is what I told, fixed protocol. When we give after 5 days of stimulation, or when the follicle is 13 or for maximum 15 millimeter, we give that. That is a flexible protocol. So I'm not going to the minute details of that. But the advantage of GnRH antagonist protocol compared to the agonist long protocol is that if the patient is having hyperstimulation, if we are suspecting hyperstimulation, means either we have to cancel cycle usually, or we have to withhold the gonadotropins, that is known as costing, that will affect the follicle quality. Or instead of HCG, we can give GnRH agonist. So when we use GnRH agonist instead of HCG, what will happen is that just like I told, there will be initially flare-up effect of the receptors, because GnRH agonist is capable of displacing the antagonist from the receptors and inducing the flare-up effect. So this causes the downregulation of the receptors, leading to concomitant LH and FSR. So the chance of hyperstimulation is less with that. So this is really advised in patients with high risk for OHSS, like young patients, PCOS, with these thin bill patients with multiple antral follicles, or typical bulky ovaries with thick stroma, or previous history of hyperstimulation, or during stimulation if the estradiol value is high, like 4,000 microgram per ml. So the preventive measures to prevent the hyperstimulation syndrome. I'm not going to whole hyperstimulation syndrome. Regarding the ovulation stimulation protocols, we can go for an antagonist protocol, and if there is chance of hyperstimulation, we can use GnRH agonist for triggering. This is being recommended by the ASRM as a protocol guidelines for preventing the OHSS. So this not only the preventing hyperstimulation, it has revolutionized this agonist triggering in the antagonist protocol, and a lot of countries have started using it, especially is in the PCOS patients, or when we are stimulating the donor patients, because OHSS is almost a iatrogenic complication that has to be avoided into the donor patients who are giving the oocyte by undergoing the stimulation. So other things recommended by the ISRM is that if the AMH value we can see, and if it is more than 3.4 milligram, or antral follicle count is more than 24, or the developing large number of follicles developing, or 3,500. There are some people recommend as 4,000 or 3,500, or during IVF if you retrieve more than 24 oocyte. These are regarded as a grade B evidence. So next advantage of this antagonist protocol is that we can combine with the same clomiphene or gonadotropin or clomiphene or letrozole or with gonadotropin stimulation. So that is the minimal or mild stimulation protocol. That is main advantage of that. So when we compare with the agonist and antagonist stimulation, agonist already ovaries are suppressed. In antagonist, it is not suppressed. So when we undergo the stimulation, in the day of HCG, the only disadvantage with the antagonist protocol, there is uneven size of follicle. In suppressed agonist cycle, there is more of a uniform follicles and more uniform maturation will be there. But the prevention of hyperstimulation is the biggest advantage. So there are a lot of points in favoring antagonists and against agonists. So I'm not going to those details. So the main advantages with antagonist protocol is that shorter duration of treatment, less injection, less consumption of gonadotropins, which are the costliest part of the ovarian stimulation. There is no flare or cyst formation. It is more physiological, less incidence of OHSS. But when we are using agonist long protocol, we have got a good control over the cycle and ovulation. It is more friendly to the physician and patient, ideal for batch IVF and follicular synchrony, as I told in the picture, and maximum follicular oocyte yield among the protocols, but maximum chance of OHSS also in those. So the other thing we must know when we are looking about the how we can refine your stimulation is that recombinant technologies, I think in future the cost will come down, that is reduces the batch to batch consistency. Next thing is that with the same recombinant technique, alpha folitropin injection has developed. That means instead of the daily injection, when we give, the action lasts minimum of 6 days, so we can avoid the daily injections in the patients when we are using alpha folitropin. It has been launched abroad of more than 5 years back, but still not launched in India. So we can reduce. So once you give the injection, you have to give the next injection after 7 days only. That is the main advantage of alpha folitropin, but it is the cost factor. That is one reason they are telling it is not yet marketed in India. So with the advent of alpha folitropin with antagonist, then chance of number of injections is less for control over stimulation in patients undergoing IVF. You can start with one injection and then add antagonist after 5 days, and then supplement after 7 days. We can supplement with the daily injections of the recombinant FSH. Same preparations can become continued. So next in the pipeline is the oral gonadotropins, which is under trial. So what would be the ovulation reduction? We must be aiming to prevent the OHSS and prevent multiple pregnancy and prevent the complications and achieve ovulation and live birth as far as possible. So for this, we must be always knowing about the ovarian reserve. We must be seeing the baseline ovarian reserve. What we have to see is that FSH level and the Mullerian hormone level. And there are some studies with inhibin, but it's not widely available in our country. And to stimulation monitoring, we have to use the E2 level. And ultrasound parameters is the antral follicle count. That is how the antral follicles, how much we can expect in the initial part of the cycle, and the ovarian volume. So these are the things what will guide us for stimulation. So also we must see about the ovarian insufficiency also. That means when the not only the hyperstimulation part, whether the ovarian function is less has to be seen. So in the biochemical insufficiency of the ovaries, gonadotropins will be elevated and fertility will be reduced. But in overt insufficiency, gonadotropins will be elevated and the fertility will be reduced. Also, menstruation will be also abnormal, and premature ovarian failure, menstruation will be absent. Gonadotropins will be elevated and fertility will be 0. So we have to identify this group with the diminished ovarian reserve. So that in those patients we can try with the adjuvants. Are there a lot of adjuvants are in the market? There are some studies supporting few, some are not. I'm not going to all those things. That is a separate presentation by itself. But what has been tried, and there are few evidences that is the use of growth hormone. There are some studies supporting the use of growth hormone. Even we have done a few studies with that, and I think I had presented it in the ASUG in Mumbai, and that was the as won the Kumar Tamaskar Prize for the for the fertility treatment. And we are tried with the 2 units compared with the higher units of growth hormone, getting reasonably good result. Also, there are some studies supporting transdermal testosterone pre-treatment before the stimulation for 4 to 6 weeks. Several studies are there from 3 weeks to 6 weeks pre-treatment in transdermal testosterone. And also very few studies with the DHEA. That is, most of the studies are confined to some part of Europe where a DHEA treatment is there, but there are few studies doubting its efficacy also. That I'm limiting with these 3 molecules. There are other molecules, so there is not much data with that. So other things what we can do with stimulation is that we can go for an ultra short protocol. Patients with poor ovarian reserve, like that initially we can give with the GnRH initially, which has got flare up effect with the receptors, and then continue the HMG. And when the follicle is good, we can give HCG also. And next is that what people have tried for poor responders is that embryo pooling. That means one stimulation we do and collect the oocytes, and another after the menstruation we give with another cycle, embryo pooling. This can be done in the same cycle also by gonadotropins with antagonists. This all have been several trial and studies have been tried because of the advent of the antagonists, where directly suppresses the receptor, so we can clearly plan and do the cycle modifications. All people have also tried with the double stimulation protocol, that initial clomiphene with gonadotropins, and when we trigger and do the home pickup, here the clomiphene citrate is given till the trigger, so that HPA axis is suppressed, but the endometrium won't be receptive in those patients, but we retrieve the oocytes. Then after the cycles, we give again gonadotropins and either give progestins or GnRH antagonists also, and retrieve the oocytes everywhere. That is known as the double stimulation protocol. So this is the new thing, new stimulation protocol instead of the antagonist. Plus, there have been studies of using progestins like metoxiprogesterone along with gonadotropins and retrieve the oocytes, because the HPA axis will be suppressed with that. So regarding the cancer patients, what we can do is that we can go for a random start protocol. So we are not bothered about transferring that cycle. Our aim is to retrieve the oocyte and freeze it, so that after the chemotherapy, radiotherapy, we can use that same patient, the oocyte embryo, oocyte received as oocyte or the embryo. So this is the random start protocol. So irrespective of the cycles, we start the HM gonadotropins and then add the antagonist as a fixed dosage or the flexible dosage, as we discussed. And that random start has been tried in the early follicular or mid follicular, late follicular, and luteal phase. All the phases people have tried, but the yield is maybe less compared to the routine protocols. But we don't have any option. We cannot spare any time for the cancer therapy in those patients. That's why we have to go for a random start protocol in either part of the phase of the patient, and do the oocyte retrieval and oocyte freezing has to be done, because that will be the after the chemotherapy or radiotherapy, the oocyte yield will be less. And lastly, group 3 disorders, that means the patients with the when ovarian failure, as I told, as ovarian markers must be identified properly, and we have to advise them as an ovarian donation only in this patient. So whatever be the ovarian stimulation, we must go for a proper follicular tracking must be done. It must be done by the transvaginal sonography as far as possible. We must see for the number and size of the follicles, and we have to always correlate with the pattern and thickness of the endometrium. In only doubtful cases, we have to go for as a poor response or hyper response, we have to go for an estrogen blood level. So, and when the follicles is usually regarded as mature, when the leading follicles is 17-18 millimeter, with endometrium 8 millimeter. In those patients, we can go for a HCG triggering. So to understand that, we must know about the basis of ovulation. When the LH surge occurs, usually the LH peak occurs afterwards and the ovulation occurs. So this time period interval, that is the basis of when we are looking for the ovulation after the follicle is matured, we have to know about it. So to ovarian stimulation, it normalizes the abnormal gonadotropin pattern, it increases the availability of the fertilized oocyte, improves the follicular genesis, increase the pre-ovulatory estrogen levels, improves the endometrial receptivity, and correct occult ovulatory dysfunction. And before starting ovarian stimulation, always define the goal of ovarian stimulation in that patient. And in needed patients, analyze the ovarian reserve, doubtful patients, and then select the correct stimulation protocol. And because the search for newer drugs and ovulation-inducing regimes and finding the ideal protocol and refinements of this different protocols which we discussed, that combines the efficacy, safety, economy, and also good patient compliance and good care and clinical outcome is going on. And each year goes by, newer regimes, newer medicines are coming up. Thank you for patient hearing.
That was a wonderful talk, sir. Very comprehensive. Are there any questions, Pratik? I don't see anything in there.
There was one question from the audience, and this was specifically for Dr. Lakshmi. And this particular person is asking, what is the role of mifepristone 25 milligrams once daily for 3 months as far as medical management is concerned? Any experience or anything Madam would like to share?
Of fibroid, you are saying?
Yes, ma'am.
That low dose is not available in India, so we don't use. I mean, in India, you can't use that for the medical management of fibroid.
Absolutely. I think that is a very clear and straightforward message. But we have very few options as far as medical management of fibroids are concerned, unfortunately, in our country. Now we have this new molecule which Madam elaborated on at length, and hopefully that will prove to be a boon for most of us in clinical practice. Anybody has any questions for Dr. Fessy? I think he gave a fantastic oration today. If I was in the audience, I would give a standing ovation because I have actually been watching him give this talk for at least 5 years. And, you know, every time I listen to him, there is something new. I get to learn something different. He adds some new protocols. He adds some new evidence. Today, he talked about embryo pooling. He talked about random start. He added more slides on double stimulation, cancer patients. So it's always wonderful to have such a senior and eminent person amongst us and to learn from such a person. Thank you, sir, Dr. Fessy.
Thank you,
for a fantastic talk. It's really nice to have you with us. So I think there are no audience questions as such, but a lot of positive comments. Yes, sir.
And one thing is that I always feel that when Pradeep, who is so well updated in things, when Pradeep calls, we have to add something. So that has to be there.
That added stress and pressure is also there. I agree sometimes. Thank you, sir. So there are no audience comments or no audience questions as such, but a lot of positive comments and encouragement for all the wonderful speakers that we've had. We had a total audience of 650 plus at last count, and this entire program proceedings are going to be recorded and put up on YouTube thanks to our academic backbone, Science Integra. If anybody has any further comments or anything you would like to say, please feel free to speak.
I just want to ask Dr. Lakshmi that new molecule, is it available in India?
Yes, sir, it's available, sir.
Okay.
We'll send you the entire thing on email, sir. You can follow up and look into the local availability at Amrita. Maybe you can even publish a paper if you do a short case series. You'll have enough patients by the time AICOG Indore happens.
Yes.
Why don't you publish a paper or present it at AICOG at least? That would be lovely.
Yes. And, regarding the poor response, I didn't go in for in much detail.
Yes,
but a lot of people are reluctant to use because of two reasons. One, it is an off-label indication. Second is most of the abroad studies are with 8 units or even 6 units of growth hormone.
Correct.
And that is very costly.
It's
and
extremely expensive, and most of our patients can't afford. In fact,
I presented that for Kumar Tamaskar price in 2013 that we did with 2 units of growth hormone.
I remember because you had presented it at Goa, and I was there for your talk.
And for 4 units, there is a brand in India which is available for 1,600 rupees. For 2 units, it will be 800 units, equivalent to 75 units of gonadotropin.
Right.
So it is worth trying. We have been using for more than 10 years now.
Thank you, sir. Dr. Charmila, Dr. Shaila, any closing comments before I present the formal vote of thanks, please?
Sir, no comments, but a lot of gratitudes and thanks for having
Most
me.
welcome. Most welcome. We'll keep calling you.
Yeah, Shaila, we need to call for Tamil Nadu also for our programs. Because we are actually providing incinerators to many schools here. Because we feel that whatever stigmas there regarding the putting of napkins in the dustbins and all that is the one which makes many girls very wary of going to school during their period times and all that. So we have provided incinerators, and we're also giving them that vending machines, that sanitary napkin vending machines. And we've also involved the local self-help group ladies so that they also get an income out of it. We've talked to the government of India and we have made sure that they procure the napkins from these self-help group women. So they also have a source of income. But during COVID, we have found out that it's very difficult for these women to have a living because it's so difficult to go and sell, because the schools are all closed now. So we are like vaccinating them and asking them to go to villages and sell the napkins at their place itself. So that is one source of income which we have formed during the COVID times. We're trying to do but it's very difficult. COVID has brought down lots of the activities, and women have actually gone back. That we have found that whatever improvements were made in the last many years, they've all regressed back. COVID has created a bad situation for women health.
Charmila, initially we were also doing this vending machine program, but now every organization is promoting menstrual cups.
Yes,
as it does not have no trash, no cash, no rash. So I like that catch line, because this menstrual hygiene day, that was the tagline, and even my association promoted that. So once we really educate the girls and women, and if they can really switch over to menstrual cups, I mean, their finances will be saved, and we will not have so much of plastic generated. So at war footing, we all have to create mass awareness about the utility of menstrual cups. So we have to shift our focus from sanitary pads and the vending machines to menstrual cups.
Madam, it's very conservative.
I know.
Very, very conservative.
I have those reservations, but the benefits are too much of the menstrual cups.
And already there are many groups who are involved in making these napkins. Suppose we promote, it's going to take off their living also. They cannot move because all of them have children dependent on them, alcoholic husbands. These are the groups who form that self-help group. So that's why, and we have made it like eco-friendly. These napkins can be easily disposed of. There's no plastic used. We use the bamboo fiber and all that. So it can be easily disposed of. And we also teach them how to dispose of in their own places also. So that
also, I believe these eco-friendly pads are manufactured at local level. We have to go all out to, as Shaila said, to let our women come out of these menstrual taboos and menstrual shaming, and we have to teach them about the latest methods, let them choose, and we have to, of course, teach them about the menstrual hygiene, because that is really a big problem. Because I also personally used to go to schools and colleges in these COVID times. I'm not going, and the experience shared were really eye-opener by the teachers and students.
But in urban areas, we are advocating the menstrual cup, madam. But for the rural students, it's still very difficult to bring them out to.
So it's a back to basics discussion today, and it's something which we don't often touch upon. So I'm really privileged to have Dr. Shaila Charmila here with us.
Talk about menstruation. It is not something to be kept below the carpet. It is not to be hidden. Everybody should talk about menstruation, including boys.
So our role as educators sometimes and teachers is something which we often don't realize, that we hold a very important and privileged position in society, which we can use for betterment and good of society at large. That's something which we forget, we just take it for granted.
And they listen to us compared to any other group. They listen to us.
Absolutely.
Not only we as educator, Pratik, we as parent, how many of us have taught our boys about the menstruation? I can say, I told my son when they were 10 and 12 years old, because he saw advertisement and he was very curious. So I told them everything. We have to start from our own, our family. We have to first teach our boys and girls. We teach only girls. What about boys? We have to teach boys also. So let us start from self, our family, our neighborhood, our immediate family, and then go to the schools and colleges. I think we should start from self. I mean,
social change is urgently required.
Yes.
So at the end of today's program, I would like to present my formal vote of thanks as the convener for today's event. My gratitude to our AMOX President, Dr. Nandita Palshetkar, Secretary, Dr. Arun Nayak. Thank you so much for always being with us and guiding us, blessing us. Thank you to the ICOG Chairperson, Dr. Mandakini Meg, Secretary of ICOG, Dr. Parag Beniwale, for granting us the ICOG credit points. We had three fantastic esteemed personalities who were speakers in today's event, Dr. Shaila Jamal, Lakshmi Srikhande, and Dr. Fasi Lui. We had three wonderful chairpersons, Dr. Kiran Kurtakoti, Dr. Charmila, who's here right till the end. I think Dr. Sujata Davi ma'am was held up in the clinic. Maybe she'll join us at another time. I also need to express my gratitude to the Science Integra team led by Subbu and Session. Thank you for being our scientific and academic backbone. Gratitude to the Acumentis Viviana team who has been there with us since the past program, and they have also helped to reach out to the small nooks and crannies of India and helped us to have wide publicity regarding today's event. We had an audience of more than 650 viewers. Thank you, viewers, for joining in. We would welcome your comments and feedback. Please feel free to reach out to us. The certificate, the ICOG credit point certificate for today's event is available at the viewer link. The download button is enabled after 3 p.m. So if you zoom out, you will see the button. Please click on it and download your certificate. We hope to see all of you very soon at the next event. Until then, take care, stay safe. God bless. Bye for now.
Thank you, Pratik. Thank you for a
Thanks.
wonderful opportunity.
And special appreciation to you for the smooth conduct and be punctual, and you finish before time.
We always finish before time.
I know. That is the USP, I think, of Pratik. Great. We really enjoyed it, and it was a very good session. Thank you, Pratik.
Thank you so much for gracing the occasion, ma'am. I think your talk went down very well. Thank you so much. Really appreciate it.
Thank you, Pradeep.